Hello to all audience. We are from SGD number B1, would like to present our student project entitled Management of Iron Deficiency Anemia. But before we going through our presentation, we would like to introduce our members which shown in the slides. For the next speakers, the time is yours.
Hello everyone, my name is Nadia with my last degree number 160 and I will explain about the introduction for this paper. So anemia is a condition where hemoglobin levels less than 2 standard deviation from the mean was considering the patient's age and gender. So there's about 2 million people worldwide are impacted by iron deficiency anemia and mostly on pregnant women and children under the age of 5 in developing nations. In Indonesia, iron deficiency anemia were 28.7% and about 48 were on pregnant women and 38 were children under 5. So the factors influencing iron deficiency anemia is age, gender, and socioeconomic level. And patients usually felt fatigue, exhausted, dyspnea, development delays on children, cognitive heart failure, and complications during pregnancy. The problem that we conduct for this paper is what is iron deficiency anemia, their pathophysiology, their clinical symptoms, how to diagnose, how to do the management, and how to choose the most suggested management by just considering the pros and cons, and what are the long-term effects of the management. And this is the objective of this paper. They are general and specific. For the general, we want to know more about iron deficiency anemia and how to put the right management on overcoming this condition. And the specific will be the same as the problem. The benefits that we want from this paper is gaining knowledge about anemia, especially on iron deficiency anemia, and providing a deeper understanding of their pathophysiology, clinical symptoms, diagnosis, and how to effectively manage iron deficiency by acknowledging the pros and cons in each solution, now and then with hopes to expand the scientific wisdom.
I'm Gus Agung Krisani Maputri with the last 3 digits of my student number R143. Will continue with the definition of iron deficiency anemia. Anemia is a state when the amount of erythrocyte and or either hemoglobin concentration are insufficient to meet physiological needs. Hemoglobin has a critical role in carrying oxygen to the tissue. Decreased oxygen distribution may affect multiple organ systems and lead to failure. Anemia has numerous possibilities for its underlying cause and disease. Anemia may be due to nutritional deficiency that lead to deficient or ineffective erythropoiesis. Iron deficiency anemia, or ID, is the most common anemia that is caused by nutritional deficiency. Iron is an essential element that is required for DNA synthesis, mitochondrial energy generation, enzymatic process, and oxygen transport. Iron is a principal part of hemoglobin. Iron deficiency frequently develops in 3 stages. It starts with storage iron depletion and the iron deficient erythropoiesis, and iron deficiency anemia may be developed if the iron deficiency already impairs the erythropoiesis process. That's all for me. Thank you.
Hello, my name is Nyoman Gedewilaguna Triparamaruta and my last 3 digit number is 180, and I'm going to explain about the pathophysiology of iron deficiency anemia. So, iron deficiency anemia, a common blood disorder, results from a complex interaction between factors that disrupt the body's iron balance and red blood cell production. Iron, a fundamental micronutrient, plays an important role in the synthesis of hemoglobin, the protein responsible for transporting oxygen throughout the body. When iron stores are depleted, the body compensates by depleting these stores, but if demand continues or worsens, iron stores won't be sufficient to maintain normal erythropoiesis and red blood cell production process. Insufficient iron intake causes various effects. Bone marrow, the organ responsible for the production of red blood cells, suffers due to a lack of this important mineral. As a result, the amount of hemoglobin produced decreases, causing red blood cells to become smaller and paler, microcytosis and hypochromia, so they cannot transport oxygen effectively. This reduction in oxygen delivery causes a variety of systemic effects, leading to fatigue, weakness, pallor, difficulty of breathing, and in several cases, potential complication affecting the muscles and various organs due to lack of oxygen. So that's all for me. Thank you.
My name is Arin Aras with the last digit number of student ID is 002. I will explain about the clinical symptom and diagnosis. The common and non-specific symptom: tiredness, dizziness, cold hands and feet, headache, short breath during activity, The serious symptoms are pale, rapid breathing, increased heart rate, dizziness, and bruise more easily. The hemoglobin level should be less than 130 gram per liter in men and less than 120 gram per liter in women. The hematoscopy shows microcytosis, hypochromia, and anisocytosis. There will be a drop in the saturation level of serum ferritin, iron, and transferrin. The gold standard for diagnosing iron insufficiency in patients can be done by biopsy or bone marrow aspiration. That's all for me. Thank you.
Hello, my name is Janeska Pramesti with the last three digits pseudo number 208. So now I'm going to explain about the definition of oral iron supplement and also how to manage iron deficiency anemia with oral iron supplement. So oral iron supplementation treats iron deficiency anemia, which occurs when the body doesn't have enough iron to produce hemoglobin. Oral iron comes in different forms including pills, capsules, drops, and extended release tablets. So how to manage iron deficiency anemia with oral iron supplement? First, identify iron deficiency anemia and treat the underlying cause of iron deficiency anemia. In example, gastrointestinal bleeding or menstrual blood loss. Prescribe oral iron therapy for at least 3 to 6 months to replete iron stores and normalize ferritin levels. Advise the patient to take the oral iron supplement on an empty stomach or with a small amount of food. Avoid taking the oral iron supplements with antacids, dairy products, tea, or coffee within 2 hours before or after taking the supplementation. Monitor the patient response to oral iron therapy by checking hemoglobin, hematocrit, and ferritin levels regularly. Adjust the dosage or switch to an intravenous iron infusion if there is an inadequate response or intolerance to oral therapy. Consult the patient about the potential side effects of oral iron supplementation, such as gastrointestinal discomfort. That's all from me. Thank you.
Hello, my name is Komala Sri Bunga Sudani with the last three digit of student number is 241. I will explain the pros and cons of oral iron therapy. The first one is pros or advantages of oral iron therapy. Oral iron therapy is the main treatment for patients with mild to moderate IDA. This is because oral iron therapy tends to be safer, more cost-effective, and sufficient to fulfill the body's iron stores. In addition, oral iron is readily available in the market in a variety of doses, compounds, and bioavailability, making it easy obtainable. Oral iron also can be routinely administered to teenage and adult women to prevent IDA. For pregnant women with a history of or high risk of IDA, oral iron supplements are the preferred choice. Taking vitamin C a few moments before oral iron can make the stomach environment more acidic to prevent the oxidation of ferrous iron to ferric iron and get the adequate iron absorption. The second one is the cons or contraindicates or the disadvantages of oral iron. Oral iron should be taken with an empty stomach. Some food ingredients such as phosphates, peptides, and tannins may reduce the absorption of oral iron. Patients with chronic inflammatory may have a limited response to oral iron therapy due to hepcidin-mediated mechanism. Additionally, for patients with a history of inflammatory bowel disease and other gastrointestinal issues, the response to oral iron therapy may be reduced due to absorption problems. When administered in high quantities, the body does not absorb all of the iron. Unabsorbed and free iron can cause intestinal irritation and inflammation, which may reduce a person's adherence to the treatment. Oral iron can also lead to stool becoming slightly hard and blackish, which may result in constipation. That's all for me. Thank you.
Hello, I'm Mario with student number 123. I'm going to explain about IV iron. IV iron is one of the management for iron deficiency anemia. It is the second line for iron deficiency anemia and should be only used when oral management is ineffective, such as in a disease, or there is blood flowing out of the body. IV iron can have serious effects such as anaphylaxis and permanent brownish stain on the tissue. The best way is to treat underlying diseases so this management can be stopped immediately.
Hello everyone, my name is Rafadiar Dravajri with my last three digits of my serial number is 244. Okay, so the pros for the use of intravenous iron, the first one is it has increased effectiveness and shorter duration for enhancing hemoglobin levels and iron in disease. The second one is intravenous iron absorption and bioavailability remain unaffected by inflammation. The third one is it has fewer gastrointestinal side effects. And then intravenous iron offers flexibility in dosing, either as a single high dose or multiple doses. And then intravenous iron has better patient compliance compared to oral iron. Okay, so now the cons for the use of intravenous iron. Intravenous iron administration requires expertise and facilities for cardiopulmonary resuscitation, and then it may affect the administration site reaction. IV iron may potentially cause fatal hypersensitivity, and then IV iron may need recurrent dosing. The side effects of IV iron may include headaches, joint pain, hypophosphatemia, and osteomalacia with certain formulation. Overdosing on intravenous iron has variable complex stability, potentially inducing oxidative stress at high doses. And then lastly, the cost of intravenous iron is higher compared to the oral iron. Maybe that's all from me, continued by my partner.
Hello everyone, my name is Asikirana with Srila student number 087, and now I would like to explain about management of iron deficiency anemia with blood transfusion. Blood transfusion is a common procedure in which blood or its component are donated by a donor via an intravenous route to a recipient. A blood transfusion is used to replace significantly decreased blood or blood component levels. Blood transfusion is only provided to patients with a significant severity of iron deficiency anemia with unstable hemodynamic condition, the presence of severe anemia symptoms, or in patients with active bleeding resulting in substantial blood loss. This treatment can directly increase hemoglobin concentration and provide approximately 200 until 250 mg of iron per unit of blood. Despite providing immediate results, transfusion will only provide a temporary improvement. Therefore, appropriate management includes treating the underlying cause. The decision to perform a blood transfusion in the context of iron deficiency anemia should be considered based on clinical factors. Preparation for blood transfusion involves pre-transfusion testing that should provide information about the ABO blood groups, resus type, and the presence of red blood cells antibodies that may cause hemolysis to ensure compatibility between the donor's red blood cells and the recipient's antibodies. Blood products are delivered through an intravenous tube equipped with a filter to prevent the entry of particulate debris. During and after the transfusion, the patient vital signs should be closely monitored by the healthcare providers. That's all from me. Thank you.
Okay, thank you for the time. My name is Yuda, and I will explain the pros and cons about using this method. To yet, the widespread recommendation for administering blood transfusions to individuals afflicted with iron deficiency anemia has been limited. It is recommended that transfusion be allocated exclusively to patients exhibiting severe anemia, those who are hemodynamically unstable, and those who have concomitant comorbids. Healthcare providers exhibit a justified hesitancy in administering transfusions to patients in situations where it may not be necessary, as this practice is linked to notable dangers. One notable observation is the elevated mortality associated with liberal blood transfusion in case of upper GI hemorrhage. Therefore, it is not possible to prescribe frequent blood transfusion for patients who are asymptomatic, especially those with non-acute anemia. The necessity of blood transfusion of iron deficiency anemia in children is infrequent due to the delayed onset of anemia, which permits physiological compensation and the fast response to iron supplementation. Okay, that's all from me. For the next speakers, the time is yours.
Thank you. My name is Gede Pramaditya Wahyu Saputra and the last three digits of my student numbers are 045. In this occasion, I would like to present the considerations in the management of iron deficiency anemia. The management of iron deficiency anemia should be assessed thoroughly, especially in patients with comorbidities such as chronic kidney disease, congestive heart failure, inflammatory bowel disease, and malignancy. Congestive cardiac failure is the most common comorbidities in iron deficiency anemia patients. The use of antiplatelet and anticoagulant drugs often causes GI bleeding that leads to iron deficiency anemia, so it is better to use intravenous iron. The treatment of iron deficiency anemia and chronic kidney disease is also similar with congestive cardiac failure, where it is better to use intravenous iron than oral iron. But it is known that oral iron, such as ferric citrate 1 gram 3 times per day, might be an alternative treatment because it reduces the incidence of death, transplantation, and dialysis. Other high-risk populations such as elderly and pregnant women should also be noted. In elderly, it is better to use low-dose oral iron as the first-line therapy to prevent adverse reactions in intravenous iron. In pregnant women, 80 mg elemental iron, which is equivalent to 250 mg oral iron sulfate tablet, is recommended. That's all from me. Thank you.
Okay, so hello everyone, my name is Ferza Husnadipa with Sri last digit of student number 102. So I'm gonna give the conclusions of this student project. So anemia is a condition wherein the hemoglobin and or red blood cells in the body does not meet the required level. One of the most common type is iron deficiency anemia. The management of iron deficiency anemia is mainly focused on the nutrition improvement, and it can be fulfilled through oral and intravenous. For the oral iron, it comes with various forms such as tablets, capsules, and drops, and they were easy to get, cost effective, and safer. Intravenous administrations, in comparison, they take shorter durations with high bioavailability, but they may cost higher than the iron. But both of this therapy was desired to elevate the iron levels in the body. Another management is blood transfusions. The indications of blood transfusions is patients with severe anemia and patients with active bleeding and when the other treatment was not working at all. And several risks can be found in this management, such as the transfusions related reactions. The second one was circulatory overload and the potential viral and bacterial transmissions. And all of these considerations should be assessed thoroughly because it is every clinician's responsibility to determine the right actions of iron deficiency anemia treatment to reach its therapeutic effect. I guess that's all from me. Thank you.
Okay, that's all from us. We would like to apologize if there are any mistakes in our video. Thank you for watching our video.